Advocates mission.
Thanks, Jim.
Start the recording. Do I
Yep.
need to repeat all that, or can we
Nope,
just go?
we're good. You just keep going.
North Star Advocates, our mission is around preventing and ending youth and young adult homelessness in Washington State while strengthening children, young people, families, and communities, and holding the systems accountable that are designed to support them. And this work here, the behavioral health work, is really about our vision to build a behavioral health system that serves all young people and families, but also those adolescents and young adults who are at the intersection of unaccompanied homelessness and a behavioral health crisis. And the Bridge Coalition is a big part of that strategy. So, again, thank you all for being here. We have a really awesome meeting. It is worth noting that we take December off. So, this will be our last meeting of 2025. And we just have a stellar lineup for you. Thank you to Sarah and the young people. And thank you in advance to all of our speakers. I will invite you to please introduce yourself in the chat, your name, your organization, pronouns. And also, I thought maybe, given we're on the doorstep of Thanksgiving, which has some complications in its history, but today I invite us to look at the joy and what it means to the human experience to be grateful. I think of my tiny Mexican mama who would tell me, Jimmy, you can be grateful even if you're just grateful to be here and complain. It's with her spirit that I invite you to identify what you might be grateful for this season. And I want to start that off by saying I really am grateful for all of you, for our partners, and in particular for the young people who have guided and worked with North Star to help us get to this point. And then I hope you'll all join me in sharing. Let's see if I can get my cursor to work. A little bit of love for the amazing Sarah Spear, who really I have just grown to adore and admire so much. And we're here because of a lot of her great work. So, with that, again, I thank you for being here. We're here at the community of Table on behalf of young people. And so I will turn it over to Mayana.
Hi, thank you. Yeah, so just before we introduce our first speaker of the day, I just wanted to briefly go over like what the bridge is for a refresher for this space, and then in case there's any new folks with us today. So the Bridge program focuses on youth and young adults exiting inpatient care, which in this case is defined as the carceral systems, mental or behavioral health care facilities, and rehab facilities. We have this focus because the data is clear that there's a high disproportionate rate of youth and young adults exiting these systems and then consequently experiencing homelessness due to just a general like lack of support and resources post care. I can definitely attest to that. Like I'm a young adult who had that experience, unfortunately. Sorry, my throat's a little froggy today. Bear with me. Um, so yeah, that's definitely a big issue, and it's not just data; it's also like lived experience. So, um, uh, yeah. Sorry, lost my spot on my script here. Okay, so with that context, the bridge more specifically has three purposes. The first purpose is info and resources, uh, resource sharing, sorry. Like this meeting today, for example, we want to really like engage with the community, make connections, make sure, we all have information about this sort of stuff so that we can really like engage and build on these things. We have developing the return to community planning, which is what we call basically what we call the discharge framework that we use for the bridge housing to really ensure that youth and young adults don't leave the housing back into homelessness, to ensure that it's not just like a repeat of the systemic discharges into homelessness, like I mentioned a minute ago, that just often happens, unfortunately, with youth and young adults coming out of facilities. We call it the return to community planning because this is just more intentional language that really reflects what we want to do, which is again have youth and young adults return to community rather than back to homelessness. And then our third main purpose is advocacy, of course. That's how we created and obtained the bridge housing in the first place, and we continue to engage with youth and young adults for input. We make sure that our advocacy is just youth and young adult lived experience informed. And yeah. So with that, I'm going to go ahead and pass it over to Sierra for them to introduce our first speaker of the day. Thanks so much, y'all.
Thanks, Mariana. Hello, everyone. My name is Sierra Phillips, and I am really stoked to go ahead and kind of introduce a couple of folks from each of our houses that we've got that was mentioned that we have. We've got one on the west side, one on the east side, and today we are going to start. Double make sure I have the right person that we're starting with. We're going to go ahead and start with the west side. So I'm going to go and introduce Blanca Gonzalez, who is the manager of Youth Haven and Bridgepoint here over in Kirkland.
Hi, everybody. Thank you so much, Sarah, for that introduction. My name is Blanca Gonzalez. I'm the program manager for Bridgepoint here at Friends of Youth West Side location. I'm going to be taking a few minutes of your time today to tell you a little bit about program updates, our newest milestones, client and staff feedback, successes we've had, and what's ahead for this program for Bridgepoint here on the west side of the state. And I just want to take a moment, foremost, to thank everybody who joined us at our recent ribbon cutting ceremony. It was a success. It meant a lot to us for you all to be there, showing the support to our community and the program and the youth. So thank you again. And this for us meant a lot as well because it brought together providers. We were able to connect with state providers and other partners and supporters who as well recognize the need for safe voluntary housing and for these young adults exiting the inpatient care. So we are noticing a high demand after this ribbon cutting ceremony. So we are getting a lot of phone calls. And so we started a wait list due to the high demand. We want to make sure that we answer everybody's questions in the community, that we address any concerns that they might have for their client while doing the phone screening with us or before coming over. We want to make sure that this is the right space for the young adult. And so the highest priority for us is, of course, the client and their success through the 90 days. We have also been able to connect with other inpatient facilities in the area and also mental health facilities, which have provided a lot of support for us, which is important through these 90-day length stay for these young adults. And so we are getting ready to expand for the second house. These couple next weeks, we are on the stages of finalizing some inspections. We are very excited about our ADA room. So that should be coming up. And hopefully we can get these individuals on the wait list ready for that second house. We are at capacity for the first house that we have operating right now. So we have 5 clients in the home, and we have been quite a bit with them. And so we are excited to see them grow and really work at their community planning. That document is so important to them, to us, to be able to create a better plan for them upon exit. And some of the feedback that I would like to share, I think I've shared this before, but I will continue to advocate for it, is the documentation barriers that these clients come from. A lot of them do not come with any documents, and these documents being birth certificates, state ID, social security cards, and they are so important for housing. Some programs do require that documentation for employment, for education. And so it just creates more barriers. So one of the focus that our program has implemented is to try to attain these documents as soon as they arrive to the program. Another trend that we're seeing is some of the coordinated entry assessment programs in housing are requiring proof of homelessness documentation, which can also be a huge barrier because how do you document and prove that you have been homeless for the past year or 2 years? And so we are really focused on that aspect right now to make sure that these clients are provided with everything that they need so that we can start attacking those barriers for them. The other feedback that we have seen, and this is from the clients and staff altogether, is how important consistency is when it comes to structure and routine. So a lot of the clients, unfortunately, there's some days that, they just don't have the motivation or the initiative to organize the day. And so that can be very challenging for them. So just having that support from staff and that structured schedule really helps them stay grounded, stay productive, stay focused on their goals, and just have a much, much better outcome. A major thing I would say, and this is staff feedback, is some of the things that we've seen with the clients and learned about them is that unfortunately, many clients have spent months, sometimes years, cycling between inpatient treatment, crisis situations, and unstable living environments. So that when they come to a structured place like this, they have a hard time with key life skills such as maintaining employment, navigating relationships with peers here in the home, managing chores, responsibilities, maintaining their space, their room, trying to have good conflict resolution skills, and setting and following routines that will help them. So that's what we work on with them throughout the 90 days as well. Staff are pretty good about being consistent and asking them, how can I help you to attack all these skills that are so important for you. Some successes that we've had, we've had many challenges, but I think this is great for us because it does help us grow, and we are able to identify quickly what barriers and we need for this program. And so one of the challenges, but I think successes for us, is the emotional regulation and stability of the client. So it can be really tough. They're coming from a very structured environment from inpatient to us. And so emotional regulation can be very, very hard for them. And so we just noticed that with consistent support, predictable structure, if we provide a safe environment, they are better at regulating their emotions. We've also learned that the clients feel better about navigating public transportation, accessing community resources independently when they have, when they're taking their medication, when they're attending to services, when they have this structure and just this huge wraparound around them. I think another good success for us would be is when we get a copy of their birth certificate and their social security card. It means a lot to them to have that document in their head, because that just means that they can move forward on the next step of their goal. Even though there are tough days, as it is expected when transitioning, I feel that we've had more good days than bad days. Clients are more engaged, they're more consistent, and more hopeful as we implement more things to help them out. We really try to pay attention to their feedback, make observations, really, really hear and watch what they're trying to tell us so that we can have a better success outcome. And just as a final, I think in the upcoming months, our priorities will include hopefully to open up the second house and be stronger for this next bunch of clients. And so we just want to work on strengthening coordination with inpatient units, enhance our support around getting that documentation, the housing readiness barrier, increasing skill building opportunities for daily living and employment for the young adults, and just being consistent, trauma-informed structure, harm reduction strategies to help the clients thrive, because we do understand that each client is unique and has different goals and needs. I thank you for all your continued support and collaboration, and thank you so much for taking the time to hear me out here, and I hope I was able to give you guys a good update around the very, very good and exciting work that we do day to day. Thank you so much.
I'm going to jump in real quick. Thank you, Blanca, very much. What a great report, and in anticipation of the one from Excelsior. Another thing I want to say, and I remind you to introduce yourself in the chat, and if you want to add something you're grateful for, but I want to say that, this is a new program. We haven't found anything like it in the country. It's not treatment per se. It's not a transitional. There's a lot of nuance to this that we're all learning together. And I want to say how grateful I am to both providers, Excelsior Wellness and Friends of Youth, for being open to that learning, to not clamping down and saying, we know how to do this, but that we're all learning together. And I know I've been in your business and will continue to be in your business, and you have received that as how do we strengthen the program for young people? And I really want to tell you that I appreciate that. Back to you, Sierra.
Thank you. Thanks, Marka. And so now I'm going to go ahead and introduce our East Side housing and people person. And like Jim had mentioned, they're from Excelsior. And I'm going to go ahead and introduce Lauren Zunker, who's the Executive Director of Transitional Aged Youth over there. So go ahead and Lauren.
Thank you, Sarah. Thank you, everyone, for having us. It's great to see all of you. Just echoing the success of the event and how great it felt to connect with people and see a lot of you in person. It was a wonderful event, and we made really good connections. And so, great work there. We're excited to also be doing our event early next year in the spring. So we'll be inviting all of you to that as well. I'm going to pass the mic to Maleka here shortly. Our program manager is out on PTO today. But some things that we're really looking forward to next week, we have North Star coming out to do some targeted training. We've had a lot of really great discussions with Sarah and Jim just about this time of year and some of the support that's needed. This can be a really joyous time of year, but it can also be challenging, as many of us know. And we really appreciate this partnership to be able to have a consult and a teammate to come in and support our staff as they care for residents in Bridge. I will say and be transparent that we are seeing referrals. They're coming in pretty slow for our program. So we're continuing to do some pretty targeted outreach to our community partners and highlighting this program. And we're hoping that it picks up a little bit more soon. And I think there's a great opportunity for us to connect with our partners, Friends of Youth, as well around maybe their wait list and seeing if there's any opportunity to support. With that being said, I am going to pass the mic to Maleka just to give an update about the individuals that are in our program and what we're learning and things of that nature. So, Maleka, I'm going to pass it to you.
Thank you, Lauren. So we currently have 2 residents, and what we're learning from them is that their plans are ever changing. We write out the return to community plan, and they have one idea when they first arrive, and then as they kind of explore Spokane and all of the resources it has to offer, then their desires change. And so first they were thinking about independent living or reuniting with family, and now they're considering continuing their sober living and finding a place within the community that will support that. And we're here to support them on their journey. And so it's been really wonderful to see them really hone in on what skills they want to continue from their inpatient setting and where they want to go. With the 2 residents we've noticed that there may be a relationship forming, and they're wonderful people. And so we're trying to support them the best way we can in terms of their individuality and the goals they have set for themselves, so that we can make sure they're going on to their next best place and not focusing in on the unique situation they found themselves in. And our staff are very aware of their experience, and so they're sharing that with the team and helping us to understand what all might be involved in that. And So I guess you could say that's a challenge in and of itself, but also a success that our team's communicating so well and being able to um, identify those quandaries that come about when we start a new program. We do have one referral in the works, and that's for a youth that or young adult that is exiting inpatient in January. So I'm working closely with the provider that made the referral in order to make sure that we're ready to accept them and that they are ready in January to come aboard. Um, this young person comes in with a lot of experience and a lot of goals. So it'll be interesting to see how many of those goals are met before they exit in January, and whether or not they're actually going to need us. So it's an exciting time for us, definitely. Thank you.
Thanks so much. Are there any questions or comments? We have a couple minutes that we can take questions, and then I am going to go ahead and move us along and introduce our next speakers who will be doing some trainings and presentations. All right. Well, with that, it is my absolute honor to introduce a dynamic duo. I just have to say we have Dr. Matt Layton and we have Dr. Poppy Gardiner. Full transparency, I've known Matt for many years and he's one of my favorite people, just wonderful. And Dr. Gardner, you're working with Matt, which means you're equally wonderful. And I've heard great things about you. I'm going to go ahead and hand over the floor to you. I am going to put their bios in the chat because the amount that these two have accomplished, I really want people to understand who our speakers are and the work that they've done and contributed. Just decades of fantastic work on both substance use disorder and mental health. And we also have a follow-up doctor coming. Katie will introduce Dr. Caverly after this presentation, but sincere appreciation for our guests today. So with that, doctors, I'll ask you to come up and tell us what you have to share with us.
Well, it's
Aw,
a pleasure to be here. We're really delighted. And Sarah, it's the Mutual Admiration Society. I got to work with Sarah, when Daybreak was in a really difficult time. And what she helped me with was to help future physicians, including medical students, get involved with adolescents, understand what the real problems are. And so, again, the opportunity to be here and to talk about research that we're doing in a way that we want the message to be hopeful to you about what we're doing. That's the delivery. And everything that Blanca said about the challenges of treatment or getting appointments, all these things that are necessary. It's the same for research when you're recruiting from a population that we're mainly going to be talking about today that's in active treatment and they're dealing with all the things in their lives. So we're asking them to be part of research at WSU. I'm a professor in the College of Medicine. I'm a psychiatrist. So I'm an MD and my PhD is in pharmacology. So what we're going to talk about today is actually non-pharmacological approaches to substance use disorders and sleep. So we want to give a very high view, and then we're going to get into what Dr. Gardner, my partner, postdoctoral research associate, is doing in terms of interviewing and actually getting narratives and stories from people involved in the system who have been homeless, who have lost custody of their children, and working on the younger side of that too. So what we're going to do is Poppy's going to drive the slides. I'm going to do the first part and give you a high-level overview of some of the fun things that we're doing to try to address a really difficult problem. So, Poppy, are you ready to share your screen?
yeah, absolutely. You should all be able to see this from here.
So,
And then yeah, I'll let Matt take the floor and I'll move on as you need me to.
so we want to emphasize non-pharmacological approaches to substance use and sleep because, frankly, my joke is I got my MD to put people on medications and my PhD to take them off. And when you're talking about this population, one of the challenges to people going into treatment is that they are afraid of treatment for any number of reasons, and being in a system when they've not been accountable to that level. and then offering them things that give them hope instead of feeling like they're stuck. And that's one of the challenges. So we're going to try to get through this today to just show some highlights about our substance use prevention studies, explore the specific role of sleep, focus on patient voice and advocacy, and share stories people have shared with us about living with addiction. So you can go on to the next slide. And back over 12 years ago, it's hard to believe, I worked with a graduate student at WSU named Amy Bender. Amy was from Canada originally and was very interested in sleep and smoking. And what we found was that we would bring people into the lab and have them do a baseline night polysomnography hooked up to all of the electrodes, all the things. They stay in the lab and we looked at their sleep. And then we had them quit smoking for 2 nights and we looked at that afterwards. What we found and what Amy published was that not quite what we found was that those who slept better and had deeper slow wave sleep, healthy restorative sleep, were able to refrain from smoking longer. So we got very interested in what was going on in substance use and sleep. And so next slide, Poppy, I started working as the medical director at the Spokane Regional Health District opioid treatment program, which still exists and it's now in its new facility. And many of the people I worked with 12 years ago are still there and have partnered with us with our current research. What we're finding and what we found was that people who take opioids, whether for addiction or for pain, have essentially sleep and disordered breathing along the lines of sleep apnea. So why don't you go ahead, Poppy? So opioid-related sleep apnea, what you may think of with obstructive sleep apnea is people who are overweight with a big, thick neck who snore, and they have to have breathing machines to get the air in. Well, there are people with central sleep apnea who that's not the problem. It's the brain is not telling them to breathe. And what happens is when you introduce methadone or hydrocodone, oxycodone, any opioid, it decreases the brain's respiratory drive. So 46% of opioid users in this study had severe sleep apnea, which means they're basically losing oxygen off and on all night long. So why don't you go to the next one, Poppy? And so at the same time, I was talking with a colleague in Pullman who actually developed a mouse model where they would be dependent on morphine. And if you give a mouse on morphine, Narcan, naloxone, they will go into immediate withdrawal just like a human. Okay, so one of the problems with rescuing somebody from an overdose with Narcan is they wake up in full withdrawal. They're agitated, they're combative at times, and what do they want? They want a fix because they're in withdrawal. So one of the big challenges is how do we get them through the withdrawal and into treatment? Well, if you pre-treat them with hyperbaric oxygen, this is a human chamber, it blocks the withdrawal from opioids. So Poppy has joined us almost 3 years ago, and we've been doing work. This is out in the valley in Spokane. It looks like a submarine because it was made by the Navy. It can go up to twice atmospheric pressure, and people get fitted for a hood with 100% oxygen to go in. So our first study is the next slide. And what we showed was that hyperbaric oxygen actually could assist adults with opioid use disorder in reducing their methadone dose. So many of you may have heard that people out to 3 months, they were on a lower methadone dose. Many people are afraid of methadone, don't want to go on methadone because they think they'll never get off. And many of them try, and they return to use. And what we're trying to do is find a clinical way forward with a non-pharmacological approach. So they were able to decrease their baseline. Now we're going to go to the next slide. And we published this. And we found out that hyperbaric oxygen didn't just help them with opioid withdrawal, it also helped them with pain reduction, and it helped improve their sleep. So this is before COVID. So essentially COVID came around. We saw a lot of increased rates of substance use and mental health problems. And once things opened up a little bit, we went on to the next study, which is showing that nighttime sleep and respiratory disturbances in individuals receiving methadone to treat opioid use disorder. So this is a study that we did to simply show people with opioid use disorder who go into treatment and they're taking methadone they stabilize. Okay. Their cravings reduce. They get much better. They restore their family relationships. They often get housing back. They get an education and transitional employment. That's the goal. And in this case, if they're taking the treatment and they're doing everything as they're supposed to, but the medication is causing them to have bad sleep and they're not getting enough oxygen to their brain. So during the day, they do not feel well. They feel sleepy, they feel slow, and it's not just because of the methadone, it's because of the poor sleep. And so what they end up doing often is using methamphetamine to try to perk up and to feel better and to think better. So what I found in my experience with treating folks is that many of them were on methadone for opioid use disorder, and they were still using things like methamphetamine. So what we wanted to do was say, can we reduce the dose of methadone safely and effectively so that they can have better sleep? So next slide, Poppy. In the study that we just did, we actually separated out two groups. Those who started into the study, there were about 20 people in the study altogether. There was a group that tested positive for their UA at the beginning of the study and the group that tested negative. This may not surprise you at all that the group that tested positive was on a higher baseline starting dose of methadone as compared to the negative group. But what we found during the study on the next slide is that the three groups were separated to full hyperbaric treatment, medium, and low dose, but everybody went into that chamber. So the submarine that you just saw, everyone went in there, and this is all three groups combined. And what you see is over 90 days, they reduced their methadone doses across all conditions by 25%, by over 25%. This is a big deal in and of itself. And go ahead and go to the next slide, Poppy. What we found was that those who had positive and negative UAs at the beginning of the study, and this is for illicit or unprescribed substances, both groups were able to decrease their methadone dose out to 90 days. And what I'm going to allow Poppy to talk about next is some of their stories. But what we found was that there was an improvement in sleep, especially in the full hyperbaric treatment group. They were feeling better and they were confident that they could stay on the lower dose. In my experience, making a 25% dose in methadone in 3 months is extremely challenging and often leads to relapse or return to use. And in this case, we're very excited because it gives us, again, a non-pharmacological approach to potentially helping those who want to reduce their methadone dose. There's half the population who does not want to reduce their methadone dose. They would say, I would be dead in a ditch with a needle in my arm if I was not on methadone. I do not want those people to change anything about their methadone dose. The other half want to get off of methadone, and we do not have a clinical way forward, but that's what we're trying to do with hyperbaric oxygen. So I'm going to hand it over to Poppy.
Great, thank you. So as Dr. Layton mentioned, I moved here about 3 years ago from the UK, if the accent wasn't telling. And I've been working with this team here at WSU on a bunch of different projects ever since. But the one that really does have my heart is this one, as I am very lucky I get to speak to service users. And essentially what I get to ask them is, where did their story begin? Where did their first substance use start? Why did that start? What did that look like for them? And then I get to have a conversation with them where they take me through the whole journey of first use into active addiction and then their recovery pathway from there. When we meet them, we're very fortunate. They are in a place where they are at clinic, they are having care, and they want to do these extra projects with us, like the hyperbaric oxygen project. But people still speak to me about things they want to do in the future. They want to go off and go back to school, return to work, have a larger family. These people have real goals that I get to hear about. So truly my heart is in this project. So as Matt mentioned, when I do interview people, something they are aware of is being on a lot of medication. That comes up a lot. A lot of people, you know, there's that 50-50 split, want to get off, others don't. And I get to talk to all of them. But to start the section that I'll be focusing on, I just want to bring this quote to the table from one of these service users who did the hyperbaric oxygen study with us. She was talking about why she wanted to get involved in this extra project and extra care. And she said, if there can be something that's not pharmacological to help with OUD, it's just amazing. And that's why I'm so excited to be a part of it too, to help others, part of it being the hyperbaric oxygen project. So we have folks who are really excited to engage with us, really see a path forward, and just so honored to get to work with these folks. The age range, just to kind of contextualize who we're working with, we did recruit people 18 years and up. We did have some folks in the more like 50s and 60s range, but usually who I was speaking with were people in their 20s, 30s, and they did recall their earlier use being in those teen, youth, young adult years. We spoke to both males and females. It leans slightly heavier on the females, but we did really get a nice range of folks that we spoke to. And while everyone does have a unique and individual story, there were some themes that came up that really spoke to the group experience. So on my next slide, I do have some quotes from people that I spoke to, and I've just put that note there as a little trigger warning. There are some sad mental health themes coming up, so just a note that that is coming up on the next slide. It is just one slide. So some of the stories I have, I've broken these into themes, like I mentioned, is the difference between those who got started on substances from prescriptions versus those who use what we've called street drugs. So this is a lady speaking, and she said she was pretty naive, that the very first time I was prescribed an opiate was my older daughter's C-section. But when I had my next kid, my youngest, before the surgery, I was already like, oh, I'm going to get that good medicine that made me feel good. She was already aware that she was going to be prescribed something that felt good. And her instinct wasn't to be particularly worried about the pain or the pain reduction, but that good feeling that came with that prescription medication. And we saw that a lot. People had surgeries, people had procedures, people had had accidents, injuries that needed a prescription painkiller. And for one reason or another, that was not managed properly, and not by the service user in particular, but by their healthcare team, by the practitioners, by whoever was meant to be controlling and supervising their medication, somewhat dropped the ball in cases. And this is a lot of times how people began with opiates. So that's one theme that we were seeing among people. A second theme was domestic violence and abusive relationships. And this did come up a lot in our females. So one of the ladies spoke to me and said, I was molested when I was a kid, and then I had a sexual assault. So the opiate abuse numbed a lot of the feelings that I have at that. And I also was in a marriage that was not good. We heard this a lot, and this did come from an early age. People spoke back to living in their parental homes, in their family homes, and it was just conditions that were not conducive to a healthy lifestyle. Drugs and substances were in the home early on, and then those relationships continued into, as this person mentions, their marriages, their relationships, friendships, people that they work with. And it truly really shone this theme of just living in a world where there was domestic violence, there was abuse, and there was just drug use throughout childhood, adolescence, young adulthood, and now into later adulthood. A third theme we have, and we have five total coming up, was mental health and other comorbidities. So someone said to me, internally, I'm sort of like running from the pain. So I've got to figure that out. But right now, the methadone is helping a lot. People were very aware of why they had been using substances, why they had had a hard time getting off of things. And mental health really came through as something a lot of folks were dealing with. And that could be for a multitude of reasons. It could be kind of like, we bounce back to theme 2, that they're experiencing violence or abuse. It could be that they have had something happen in the workplace, or they've lost a job. I also spoke with people, both men and women, who had, as Matt mentioned, had children taken away from them. So these folks really had a lot going on outside of being someone with a substance use disorder and using methadone clinics. There's really a whole picture going on centered around mental health and other physical health comorbidities. The fourth theme, and this one I've picked out specifically, was motherhood and caregiving. We did have fathers on the team too. One man really did speak about his role as a father, but it really came out more from the women in the group about motherhood and their role as a caregiver to their families. And this quote here, "Mum, please, I can't live without you." This is a piece of work that I have taken to conferences and presentations, and it's the title of my piece. because this lady was speaking to me about how she had had a failure in her clinical care. Her clinic had really let her down with a very heavy miscommunication, and she felt she had been kicked off of clinic, and she did not see a way to get better and to recover without clinic. So when she thought she'd been kicked out, this really sent her into an awful mental health spiral where she was suicidal, and she had made some attempts in that direction. And unfortunately, it was her child who came in and found her injured and helped her and wrapped her in towels, but said to her, "Mum, please, I can't live without you. Please don't do this." So that there's a reason I've picked that one out specifically, and that's the thing that I've taken to presentations, and we're writing a paper on that because as mentioned in theme 3 and then above again theme 2, we have this cascade of things happening behaviorally that lead to mental health, that lead to suicide attempts and suicidal behavior from people. And it isn't just our mothers, but that was just a fantastic quote that I can't not share when I do this presentation. And then our final theme was methadone clinic support and counselling. And we really did hear great things. So many people said they wouldn't be here without clinic, that they love their counsellors, they love their support group, they love being with their peers, and they really take value from it. In this quote here, "The turning point for me was when I couldn't get clean on my own. I was tired of feeling constantly sick and having this motivation to not feel like these constant withdrawal symptoms and trying to get off it on my own." When I interview folks for this project and I ask them, how did you get onto clinic? What was your turning point? People say this. They say they just reached a moment where they couldn't do it on their own. They needed connection. They needed a clinic. They needed support. Something just clicks for them where they realize they can't do it alone and that they are not alone. And we had so many people have wonderful, positive, inspiring stories about how they got onto clinic. I had one lady talk to me and say that she's now got her son on clinic. I've had people bring their friends to clinic and they tried to get their friends to sign up to our hyperbaric study. There really is a cohesive network there for a lot of people. So I like to have that as my final theme there, to bring a little bit of positivity to things at the end of the stories, but just so privileged that people do share this with me. So in future directions, I am applying for some more funding to pick up that work I've just done and explained to you and bring it to more of the young adults who are using the methadone clinics. At the moment, as I said, it is 18 plus. We hope we can maybe nudge that down to 16 in this second piece of work, but really focus on that age bracket up to about 25 and see if folks in that younger bracket are saying the same thing. I believe they will be. We just need to have the research there to write a paper on it and see if that's truly happening, but I believe it is from my experience. Another future direction, we are expanding our network from Spokane, Washington out to Portland. We have some really great connections there working in the OUD and addiction space. And then wider to that, we do have a great team across the Pacific and in the Northwest who we're hoping to expand to. One project we're looking to take down to Portland is a project on TMS for opioid use disorder and alcohol use disorder. A little bit about TMS. I won't go on about this too long as I know we are tight on time, but essentially what transcranial magnetic stimulation, or TMS, is using a machine with a magnetic device to stimulate certain brain areas that are maybe not functioning up to speed or hitting rates that we want, or they're just more turned off than we would like. And we use the magnetic stimulation to turn those areas on. And this has been used a lot in addiction already, cigarette smoking. It's also used for obsessive compulsive disorder and depression. And we've seen some really great results in the behavioral and mental well-being space in using TMS to help with people's recovery through those clinical pathways. And we're hoping that we can show the same thing with opioid use disorder and alcohol use disorder. That's all I'll say on that for time, but if you do have questions, please feel free. So that is one of our next directions, but I will then bounce it back now to Matt to share with you the take-home message and some thanks.
When Poppy and I were talking about this, I think the main takeaway message for me is that we are actively collaborating with community shareholders, stakeholders, providers, people, families, advocates, to try to do meaningful research to drive policy and to change the availability of resources based on, for example, patient-centered care. I was very much part of starting the new WSU College of Medicine. And a couple of the pillars of the new curriculum for future physicians, one is trauma-informed care. You guys know very well what we're talking about there. We're now teaching all new physicians to approach their patient, each patient, from a trauma-informed focus. And when you talk about patient-centered care for someone who's dealing with opioid use disorder and PTSD and depression and anxiety, now you're talking about, are they actually getting a comprehensive evaluation? Or is what's happening, they have to fall into a specific silo to get funding based on their diagnosis? Now, I've been in Spokane now for 26 years. I was at Spokane Mental Health for the first 9 years that I was here, dealing very much with community mental health and co-occurring disorders. And I have had the good fortune of working with Excelsior, placing medical students there, nursing students, trying to help bring community providers in so that our healthcare providers are not being trained in a vacuum. We want this kind of conversation so that we can have the back and forth. So when we ask an opioid treatment program, can we come into your facility and do research? It's a big deal. What do you think is the most important consideration? For example, we have to go to human subjects committees to get approval to do this research. And my guess is you'll understand what the number one issue is. It's confidentiality. It's protecting people who are in a vulnerable position and who have already lost everything in many cases. And now they're just getting their lives back together. And we're asking them to sign consent forms so we can look at their clinical information. And as part of doing that, we have to comply with federal and state laws. So we enter into what are called data use and sharing agreements that are reviewed by legal teams, ad nauseum. And every step of the way, we're about protecting people's confidentiality and trying to give them the opportunity, because when you give our people who are in these studies an opportunity to tell their story, they're doing it. And what Poppy is doing is collecting stories and narratives that we can take to advocates and policymakers and say, look, this is what we need. So we could not do this without our people, our study participants, our clinical partners at Spokane Regional Health District and Oregon Recovery Treatment Center, which has now 7 or maybe 8 clinics around Oregon and Washington, including in Spokane. And we have WSU undergraduate and graduate students, and Poppy as a postdoc, and other faculty who understand the importance of doing this work. Because if we can actually help people sleep better, eat and drink and get better nutrition better, and exercise more, what we know is that is good for health. And that's what we're teaching our future physicians. So can't thank you enough for the time that we've had to be here with you. And Jim, I see your hands up.
Yeah, I can't help myself getting out here. Thank you. I found this very, very interesting and really, really, as you say, hopeful. So a comment and then a question. The comment is, if you're at all interested, I think Sarah and I would like to have a conversation on your thoughts around doing some of this research with young adults, particularly if it includes young adults who have experienced unaccompanied homelessness, and if they were allowed to participate in the design and the kind of shaping of the project. So I just put that there to
Sign me
again.
up. Sign me up.
Me too.
You're all
Yeah.
in.
Let's set it up. I think we have some philanthropy contacts that might be interested in this as well. The question I have is, so I love it. I really do. Secondly, though, in terms of methadone and that focus, have you thought about expanding it to the fentanyl experience and how this research might translate, or are there's already some learning about that? But just your thoughts on how fentanyl fits in your work.
Well, the transition, and I'll say that, so my first stint at the health district was 2014 to 2017 or so when we started the medical school. And we went from 500 to 1,000 patients in 3 years. So it was a huge boom, but at the time it was prescription and it was heroin because people had been taken off of their prescription opioids. And so they were going to the streets and they were using illicit, unprescribed, and they're using heroin. And then right around 2019, we saw the curve start up with fentanyl. So it had been around much longer, but the meteoric rise in the use of fentanyl is driving almost all of the overdose deaths that we're seeing in Washington state and arguably nationally, right? Because some of you may have actually worked with Poppy and I 3 years ago when we tried to get funding from SAMHSA to try to administer folks first Narcan, naloxone, and then buprenorphine in the field to get them save their life and then get them into treatment. And we had providers agree to hold spots for Suboxone patients. We didn't get the funding, but the main argument we were making is this is 80 to 90% fentanyl by that point. So what was that, 2022 or 3? Early 20?
Early 23 when I
It was
first started.
90% of the overdose deaths were already fentanyl. So it is baked into what we're doing to try to identify what they're using, Jim, and then their methadone doses are higher because of fentanyl. Right. That is, we're seeing that. It takes more and it takes longer to stabilize. So it is absolutely at the forefront of what we're looking at. And I think what it's changing, to answer the question in the chat, is unfortunately people, and again, this is testimony to addiction hijacking the brain. All right, this is the way we look at it now. Addiction hijacks the brain. It takes away rational thinking. So you hear that one of your friends has just died from getting drugs at a certain house, and they go to that house to get those drugs, right? And that's what has happened with fentanyl. And so even, more, what is happening is you may need 3 doses of Narcan, right? May not just be 1. You may need to treat them all night long and keep administering them. So if they say you wake them up once and they say, I don't want to go to the emergency room, I'm not getting in that ambulance and you can't make me. What we're trying to do is bring peer support in to say, this is the chance. We want you. I have been there. I didn't want to go to the emergency room. I didn't want to go to treatment, but when I did, I got better. And now I'm here to try to help you. So I think that's one of the things people understand. They can go and they can go fast. So I want to just give a chance to everybody. Sierra, you have a question.
Yeah, I just was curious, with the TMS stuff, if there was any reflect on or any studies that have been, because I know, so for me personally, my doctors have found, I guess, the balance of naltrexone and Wellbutrin have been found to be good for, because my substance and history is meth use, and so they found that in itself, those two combined, and I know it's typically was initially found to be helpful for alcohol. I'm curious if there's been any study with TMS in relation to meth use for folks.
Methamphetamine?
Correct.
What we're finding is there are bits and pieces of research out there, but there are a lot of gaps. One of them is that it's not been studied in women. And I'll let Poppy, can you want to talk about your literature review?
Yeah, so when we started forming this project, obviously one of the first things we did is go out there and see who is doing similar, the same, something on that pipeline. And like Matt said, there are bits of studies. Someone's done maybe, just 10 male participants, and we just gave them 1 week of TMS to see if they could handle it, and looks good. But yeah, in that research, there's definitely, as is typical in healthcare clinical research, a lack of female representation. And then those who did include men and women, they just kind of didn't see the program all the way through, or their outcome measures didn't quite capture everything we wanted. So people are in the early days. There are sprinkles of this happening, but I think we will be the first group to do a very coherent methodological sound follow-up of how this looks. So the idea is definitely out there. It's starting to get traction, but we should be one of the first groups.
All right, thank you.
Yeah, thank you.
And in the last minute,
Yeah.
I also want to add that we are looking at natural products as well. Okay, so I have a DEA Schedule 1 registration, and we're looking at potential uses of cannabis, CBD, and THC. I would like to study ibogaine. I would like to study psilocybin. And I want you to hear this from a scientific standpoint because I believe there are reasons why people are using these, especially in a ritualistic way, right? When you have a community and you have support, we've seen improvements in depression and substance use with psychedelics, right? But they're plant-based, they're natural-based. So again, I want to be very careful and walk that line. We're also looking, and Poppy's looking at folks with ALS. So Lou Gehrig's disease, looking at with brain injury and with Huntington's disease, and they also get addicted to pain medications. And one of the things that they're using is natural products to try to help themselves. So Poppy's been interviewing them as well to try to say, look, we should be doing the kind of research that helps people understand what their good choices are, what's safe, what's effective. You want to add anything to that, Poppy?
No, you summarized it so nicely. No, that captures it really. It's about we don't want to shoo people away from substances completely because, like Matt said, there is a safe and clinical way that these things can be used effectively, and we just want to look after people essentially. Of course, we don't want folks going to the houses where there's the fentanyl that will kill you. That's not where we want people to go. But if we can help redirect that to something else and use something that has more of a track record, a safety record, then 100% that's where we'll be. So anything that focuses on, as Matt said, person-centered care and helping people make their choices and allowing them to make their choices, but just finding a safe way to do that and, you know, navigate that with them and point them in the right direction rather than pushing them away from any direction. That's how I would say.
Really
Yeah,
appreciate the opportunity.
Yeah, really appreciate it.
I just have to say thank you so much. Thank you. I really look forward to more conversations. I wanted you guys to connect with Jim, but also the whole coalition. And we will definitely have you back because I know we've already talked about other presentations, but also on this. I really just think it's in such alignment with the work that we're all doing as well. So thank you both. I know you're tight on time. But again, thanks so much.
Thank you, guys. Thank you for interviewing.
Absolutely. All right. Our next presenter is our parent advocate, Katie. I'm going to let you take the floor and introduce yourself. And please, and we have Dr. Caverly, and I know you're going to do an introduction for her. But again, another fantastic presentation. So Katie, the floor is yours. And if for some reason, oh, you're good. I can hear you. I knew you're
okay. I just wanted to make sure I'm actually, I don't know what's happening. I was like construction right next to my apartment. So our Wi-Fi went out. So I'm kind of in a neutral space here, third space. But I just want to reintroduce myself. I know some of you have met me before, but just for the record, my name is Katie and I'm part of North Star as a parent advocate. I worked with Jim at OHY for several years, and that's how I'm connected to this group. I did lose my son to an overdose in 2021, and that occurred just hours after he was discharged from inpatient treatment, which he went to willingly as a 19-year-old. So that's kind of the intro to my connection with Dr. Caverly. And I did also put a link in the chat earlier to Jada's Community Support Fund, which is the legacy project that I've built in my son's honor. So if you're curious about that. And so in light of that situation, I was working with some attorneys to get some answers to what happened on his sudden discharge. And that's how we got connected to Dr. Caverly. So she reviewed all of Jaden's chart notes and really helped us kind of understand what went wrong in his discharge process. So Dr. Caverly is currently the Executive Director of Behavioral Health at Columbia Valley Community Health. She previously worked at THS for nearly 30 years, and she has just done some incredible work regarding youth co-occurring disorders. So I'm going to hand it over to her just because I feel like I'm in a space that isn't really conducive to me talking more. So I just want to give her the floor and let her share her presentation that she's put together. And thank you so much for being here. Oh, you're muted still.
Okay, I'm muted and I'm trying to figure out how to share my screen because I normally use Teams.
I can share if you need me to also.
It might actually be better if you do instead of me kind of fiddling around a lot.
Yep. And then you just let me know when you want the next slide, but I think I have it right in here. So just everyone give me one moment because I have got it. I'll pull that up for you.
While you're doing that, I'll tell you a little bit about, I think, how I even got identified to work with Katie. I've actually, Jim, you may not remember my name, but I remember yours from back when I was seeing patients at Straley House. Well, it's been a while. And then I worked at Seattle Counseling Service for sexual minorities for quite some time, and at Seattle or at Therapeutic Health Services. So there's a lot of places that I have been involved in a lot of direct clinical work. I've taught at the UW and I've done my teaching gigs, but what I really prefer doing, frankly, is working with the people. And so that's where I end up focusing most of my stuff. Therapeutic Health Services, however, gave me a really good opportunity to collaborate with Paula Riggs from the University of Colorado at Denver, who has made a fair amount of she's done a lot in terms of the world of adolescent co-occurring disorders and started a program called Encompass after some multi-site clinical trials working with kids who were using substances and determined that they also had mental health challenges. And oftentimes, and that if you treated the substance use with motivational enhancement, cognitive behavioral therapy, and some contingency management in a short trial, her results actually showed very little difference between the outcomes that she found and the outcomes that were found with kids that should have been in long-term inpatient treatment. That to me was really kind of profound. And when I started to work with her, I had been at the methadone clinic for a long enough tenure, like 10, 20 years, that I had seen generations. I'd seen parents and their kids come through methadone. And what became really clear to me was that we weren't doing enough as a profession, as a community, to prepare kids who we knew were going to be at risk. And that if we could find a way to help those kids, maybe we wouldn't have so much of the generational challenges that they were facing. You know, I know that that's pretty simplistic, and certainly life is not that easy, but it did seem like there were some things that we could do. And at the time, not unlike Matt Layton, I was pretty pharmacologically focused. And where I found myself was looking more at the psychosocial interventions. And so I commonly tell people also that basically I prescribe a lot of medications, but I take more people off medications. Having said that, medications are kind of critical in the work that I do. So I would never, ever tell anybody prematurely to go off medications because I think that's really scary and dangerous. And as you'll see in terms of some of what I'm going to conclude with, is that I think that that's one of the places our substance use programs have been failing people, because we've known for years now that people should not be released from a period of abstinence if they have an opioid use disorder without having access to naloxone. And with fentanyl, I would say lots of it, and certainly a knowledge about how to get it. So that's just one example of how I think we're underplaying medications sometimes in substance use treatment. So where I found myself most recently has been Columbia Valley Community Health in Chelan, Douglas County. And part of what led me to want to take this job was because I had for several years been over here primarily, and rural areas have very few services for anybody and almost none for children and adolescents. And so I took this job, and I'll share at the end also about some of what we've been able to get done in the last couple of years, which is sort of the miracle of the federally qualified health center. I've never had this experience before, and it's been kind of remarkable. So can we have the next slide, please? And we're going to go through these pretty fast. So basically, this is just how I'm going to cover this. It's a hodgepodge of things, but in listening to Sarah and Katie, they all seem to kind of tie together to make sense for coming to you today. And hopefully it's not going to be too hodgepodgey. So I just framed the issue. I think one of the challenges is that we don't have enough resources. One of the other challenges is that we try to put kids into an adult box. And by kids, I would say anybody who I'm starting to go as far as under 30, but anybody who is under 25 for sure. We're putting their treatment in adult boxes, and we're expecting the 18 to 25-year-olds to behave like adults, but we're also not necessarily tailoring care for the younger adolescents in a way that differs dramatically from what we provide for adults. And that strikes me as being so bizarre. That there are some best practices that have been coming to light over the last decade or two, and I'm not seeing them put into actual practice very often. Treatment discharge challenges. I mean, the state has finally recognized some of them. I also know that they're still not being addressed properly, because I see a lot of people getting discharged still. And then I just thought I'd hopefully have a couple minutes left to talk about what people are experiencing around this and how it fits for your experience, because this is my experience in terms of what I see in treatment. Next slide, please. So this is from the 2024 data set, and SAMHSA is like recognizing that right now, when they did their surveys, they came up with, what is it, 792,000 adolescents from 12 to 17 have a co-occurring mental health disorder and substance use disorder. What I would put to you, and we can actually go on to the next slide at this point. Well, actually, that was the wrong one, but we'll do that one. What I'd put to you is that I don't really know. Well, actually, that is the right slide. I don't know where they're getting this data, because the kids that they really need to be asking are probably not being included in their surveys. And I know if we look at any of the data from the Healthy Youth Study that comes out every year, it's focused, and that the SAMHSA data isn't focused on healthy youth, but the Healthy Youth Study that drives a lot of decision-making in terms of policy for adolescents looks at kids who are in school. And I need to tell you that most of the kids that I've worked with are probably either not in school, or they're going to know they have a survey to do and they're going to skip that class. So a lot of the folks that we'd want to access the most to find out what's happening for them, we're not even surveying. So when we look at the numbers, and we look at things like suicide rates, and we look at substance use rates and mental health rates, mental health symptom rates for the kids in the data sets, I think we need to be cautious that were missing the most at risk. Okay. The other comment that I'd make about this slide is this was from the Pendleton Rodeo. And I looked at the sort of saloon girls and I thought to myself, you know, back in the day, these would have been the people that would have been my patients. And they would have been kind of looked down upon by most of the good people in town. And I think we're still doing that to a lot of our young kids and marginalizing them from opportunities. And so I was really happy to be able to come here today. I think it's really critical that we shift as much of the ground for these young people as we possibly can, because it's hard to get out of that place that you've been kind of targeted. And if when you're trying to do that, you really need to have the opportunity to feel good about yourself. And when people are kind of pushing you to the side because you're the kid they don't want their kids with, it makes it an awful lot harder. Next slide, please. So I'm not going to go over this in detail at all, but what we know is that the younger kids start using, the more consequences they're going to have. The big one that I don't think it's talked about often enough, and I noticed this at the University of Washington when I worked in the Student Health Center, young people don't have time to get better. They're going to lose a lot in a very short period of time. So the more that we can do to identify when struggles are starting to happen, instead of putting our heads in the sand, the better chance we're going to have at not having them lose all the normative development that they need. And that's one of the places that I really wish as a society we were doing a better job, because when we do, kids actually do get better. Next slide. So you'll notice I'm doing a lot of pictures. This is my grandson, and I was really struck by this slide and the next slide. He's kind of moving from a place of being cautious, and he's thinking about what he wants to do, to sort of thinking, oh, well, am I going to go toward that water or not? And then next slide, he starts going, but he's ruled out what the risks are. And the day that I saw him do that, I felt a little bit like Piaget, because I thought to myself, I'm like looking at this kid and I'm seeing his brain work, and people are looking at me, aren't you going to go get him? Because he was in my care that day. And it's like, no, I want to picture this because he's thinking and I can move faster than he can. So I looked at that and I thought, you know, this kid actually has some cognitive stuff going on that is boding well. And that was important to me because he was born 3 months early and I didn't know if he would have that. And so he's a very lucky miracle baby and made me really happy. Okay, move on, please. Engagement is the thing that I think we miss the most, probably in a lot of substance use treatment, but even more so with adolescents and young adults. And again, it's got to do with that. There are so many rules that come into recovery that get pressed on people just at the time that they're trying to individuate. And rationally, it's not developmentally appropriate for them to just kind of bow to all of these new rules, all of these very stringent rules. And yet we have those expectations. So what ends up happening is we see them kind of drift further and further away. Next picture. What we know from some of the more recent research is that prevalence among young people with mental health disorders tends to be really high for substance use. And the data is starting to show that more and more. Next slide, please. And in that study that I just showed you, anxiety, depression, ADHD, and high-risk substance use and SUDs are often leading to that isolation, to that pulling away from everybody, which tells me that we need to really highlight the necessity of pulling them back and figuring out how to do that. Next slide, please. Here's another one that talks just in 2021 about what the evidence-based treatment for young adults with substance use disorders seems to be. And then I'm going to pull you to the next slide. So Hadland came up with a bunch of principles, and it's interesting to me that he came up with these in his research in 2021, because you'll see in the next slide, Paula Riggs, that University of Colorado researcher, had kind of said a lot of the same things. And I started working with her in 2009. And I'm still not seeing this in practice, but we knew this. So we know that young adults should be offered care that's accessible as soon as their needs are identified. I would say the same thing for adolescents. And we know that what they need is they need comprehensive care. It's got to cover a lot of bases. It's got to have a good assessment. And far too often we sort of go with a gain and we're done. And that's really not an adequate assessment level. It's a good start. It's a really good start, but it's not really as much as we ought to be doing. That we need to be really targeting pharmacologic treatments if we're going to use them. And far too often what I'm still seeing in the community is a lot of darts being thrown because that assessment hasn't been adequately done. And the recovery services that are offered to kids should be supported by evidence. Now, having said that, I once heard somebody report, and I've seen it documented, that AA is an evidence-based practice. There are a lot of different forms of evidence-based treatment. We just need to find the best fit for the person. And as far as adolescents and young adults go, we've really got to make sure that they're having some control over what they pick for that evidence-based treatment they want. That goes for everybody, but more for them. And, finally, when Bob Day started, oh God, I can't think of the name of the organization, Science and SAMA, which is no longer around, he was saying then that we need to be really evaluating our programs. And that's also something that is just in its infancy. So these are some of the principles that I would really encourage that we try to see more in the programs that we provide. Next slide, please. So this is that slide. This one is really important to me. The idea of repeating measures. When we talk about the assessments, more often than not, people have an assessment at the time that they come into treatment, and it's usually a pretty standardized, something like the GAIN that we try to get through as fast as we can because people are not feeling good and they don't want to really do it. And we have a time frame that we've got to get it done within. And so we're doing that somewhat comprehensive assessment then. But then when are we repeating it? And are we repeating that whole assessment, or are we repeating a little bit for treatment planning purposes just to check off a box? What are we doing with it? I would put to you that if we really want to promote progress in any kind of treatment, that we have repeated measures done all the way along the way, that they need to be happening a lot more often than 3 to 6 months for somebody who's just entering into treatment. Maybe somebody we've known for several years, that's fine. But for somebody who's young and changing and the world around them is changing and the things that they're required to do are changing as they grow, we've got to be doing this more often. And if we do it more often, we're going to get buy-in. And this has been my experience. Kids complain about doing these repeated assessments, and then they start getting really interested in how they're doing on the scores. And are they showing any improvement? And did anything change? And then we get to come in and we get to tell them, this is not going in the direction we want it to go. We've got to do something different. And it's not about you not getting better. It's about me needing to figure out how we help you get better. And that we, maybe we let's go revisit that diagnosis. Maybe we don't quite have it right. Or maybe this wasn't the best living situation for you. What can we do that's going to maybe change this and work in consort with the young person? So this is probably my favorite slide. Next slide, please. So this is an old slide. I presented this one back in 2017, but it was Paula Riggs' recommendation for treatment for adolescents. And I think that a lot of the same things in terms of letting the kids help drive what was happening for them, and also recognizing that we need to reconsider what we're doing and that we need to sort of be the person there to help them. Yes, Jim.
Thank you so much, Doctor.
Did I talk too long?
No, not at all. Not at all. We are coming up on time, but you just have so much to share. I guess if you could allow me, I'd love to know, because I want to make sure we get this in. You know about bridge housing, I'm sure.
A little bit.
What, 90 up to 90 days for coming out of inpatient. What, in terms of thinking about that house staff welcoming Jim, who, to your point, I've been recently clean off fentanyl or some opioid or meth or alcohol for a period of time, and it's new, and I'm coming to this less structured but safe place. I'd love to hear what you think that I, as a staff person in one of those 90-day programs, need to know.
I think the first thing I would say is you need to know that you need to look happy they're there. Because over all the people I've worked with, most of the kids that I've worked with have felt like they were kind of being thrown away, especially when they got put into treatment. And somebody celebrating that somebody's there, even if they're cranky and they're not wanting to be engaged, is probably the absolute best thing that any of us can do for anyone. I mean, I firmly believe that. The other things that I would say is that we need to be more focused on what the person asking us for help wants to get out of it than what we want to see them get out of it. And I see far too many treatment plans from people who have been doing it a long time, and also from people fresh out of school who I might expect better from, that the treatment plan is boilerplate, and it doesn't really necessarily, even if it's patient voice, it doesn't necessarily have something really resonating with that particular individual in it. And if we can find a way to have it be a partnership, that's probably the best thing. And that's why I love motivational interviewing, because we can be a little directional, because if we're just supporting behaviors that have been ineffective in the past, we're not really doing anybody any good. But if we can find some ways to be directional without being directive, that's going to make a big difference. And then the other thing I would say is that SAMHSA years and years ago was recommending that we do universal assessments. And if somebody is coming somewhere for substance use and we're failing to really evaluate their mental health state, or vice versa, then I think we're failing them. One more thing, it's in one of the later slides that I sent on. I didn't actually think I'd get through them all. But that we need to start preparing for discharge the day somebody arrives, and not have stuff be just thrown at people in the last week they're there, even if it's a planned discharge, because that's really, really common. And so if I can see other people have had that experience. It's not an okay thing that we do for people.
Wow. And I hope we can invite you back because you have lots to share, and particularly, I'll admit, drinking my own Kool-Aid. I know that if you were at Straley House back in the day, then you've had a long time commitment to this population. So, um,
Yeah.
any closing comment you want to make?
I guess one of the things that I would make is that the kids are probably, it took me a while to get there, and it took me a journey with my own daughter, but I am very convinced that the more that we can do to help kids early on, and whenever their troubles start to begin, that's where we really need to put a lot of our effort. We really, really do. And I guess there's one other thing I would say is that far too often we look for blame, whether it's with the patient not doing something right or a parent not doing something right, that really what we need to start recognizing is that everybody, including us, are probably doing the best that we know to do, or using the best resources that we've got. And that if we could just all stop finger pointing and having people not excel at what they can bring to the table, we could probably accomplish a lot more. And then the very final thing I want to say is that I was really excited to hear about Bridges, and would love to see anything to support this population in North Central Washington.
Yeah, well, thank you so much. That's why we chose when we wrote the law that there'd be one on the east side and the west side. So at least we got one in the east side. And then part of what we hope to learn from the two programs is what is next? Is it another 90-day program, or is it more long-term housing? But we'll take a year to sort of see what the data tells us. But what a great message in terms of welcoming and celebrating young people's courage when they come into the program for this Thanksgiving season. Sarah, anything you want to say as we close out? Thank you again to all of our presenters. I can't say that. I think, a remarkable hour and a half.
Yeah, I just want to echo that and say thank you. And Dr. Caverly, I hope it's okay. Can I send your presentation out to
Yep.
the group too?
That
'Cause there's
was why I
so
sent it to you.
perfect.
It's not the most polished I've ever done because I threw it together fast, but it seemed
Beautiful.
like it was the information.
No, it's great.
Well,
And
I say I'm still proud to work at Etch-a-Sketch, so kudos to you for getting the slides going. And I do hope,
thank you for running them.
oh, 100%. I hope we can count you. And thank you, Katie, for setting this up, connecting us. I hope we can count you as part of our resource bank
Yeah.
as we go forward. And you'll see the picture, thank you, Sarah, of the ribbon cutting for Bridgepoint. In Kirkland, we had several representatives from both sides of the aisle. We had the governor's office represented, the mayor of Kirkland, board members, Julio Cortez. You can see, as I'm looking at it, he's fourth from the left. He was our prime sponsor, and next to his, on my right, his left, is Representative Eslick, a Republican legislator who signed on number 2 on the bill. So. And then we have the ED's CEOs from both Excelsior and Friends of Youth. So, again, as we take care of other people in our lives, I hope you remember to take care of yourself, give yourself some patience and grace. To those running the Bridge Housing and any 24/7 program, I know while I'm eating turkey and watching football, many of you will be at a house taking care of other young people away from your families. So I want to recognize that. So with that, I'm grateful for all of you and for this opportunity we have in front of us. And I'm remembering that 15-year-old and that 22-year-old under the bridge who's hoping we do good with this opportunity. Thank you all.
thank you.